So this is a patient with interstitial lung edema. I'll make it a bit big so that you can appreciate how many septal lines he has in his lungs. So they are both numerous and large. And for those that are trainees, this will be a really nice example of curly B lines down here. But of course, there are lots and lots of septal lines that are sometimes called curly C lines when you image them two-dimensionally in the chest. And we have subpleural interstitial edema in relation to the minor fissure. And I'm looking for, but I don't see any nice examples of peribronchial fluid cuffs, but very extensive interstitial edema in the form of septal lines. So let me show you the CT. So that is on the 6th, and here is the next day. And what is really striking about these thickened interlobular septa is how thick they are. So let me just go down here first, give you an idea how thick they are. In fact, in some locations, like down here, we have what we call septal lakes. So these opacities here that are somewhat rounded, somewhat oval shaped, represent very thickened interlobular septa. And when those septa are seen like this, it looks like nodular disease. So here is a oval-shaped nodule in the periphery of the lung, and there are other ones as I'll scroll around. And sometimes if you don't recognize that these are septal lakes of interstitial edema, one may potentially describe the lung edema, but also suggest that there's a separate pathologic process that's nodular lung disease when you see opacities like this. But it isn't. This is just very florid septal edema with septal lakes. Of course, we do see peribronchial fluid cuffs and pleural fluid. So florid interstitial edema with septal lakes. In this person, we do know that this got better. So this is on the 19th. That first radiograph was on the 7th of February. And you can see it cleared very nicely. But the etiology of the lung edema in this person is kind of obscure. You can see here is the presentation. He had a number of things. He actually had bronchoscopy and the BAL. Everything was really negative, but he got better, and his ejection fraction was 63%. So I don't know what the etiology of the interstitial lung edema was. It got better, and really nothing really else panned out. There's a question of some renal disease, but I don't think that this was necessary at the time, because I think the findings are absolutely typical of lung edema rather than some other process that may require bronchoscopy and BAL, as you see there. So a really dramatic example of so-called septal lakes, we call them. Initially, this was described by a Belgian radiologist. He and his colleagues called these lymphatic pearls. I don't think that lymphatics can be this distended with fluid, as far as I know, but they call them lymphatic pearls, but those of us that seen them call them septal lakes. So things like that.
Howard, I wonder if he could have preserved heart failure with preserved ejection fraction.
I don't know. He's way too young, right?
Which I think actually more so diabetes.
Pardon?
I think the heart failure with preserved ejection fraction is actually more closely associated with diabetes. So I'm not, maybe a possibility to explain it, but maybe they would have it on the echo.
Yeah, I don't know. It's a pretty dramatic imaging appearance, huh? All right. This one we've certainly seen before, but because it's such a dramatic example, I'll show this one to you. So the imaging findings, and I'll show you a couple more projections, are those of both rheumatoid arthritis and by virtue of acroosteolysis, in looking at the distal phalanges and the absence of some of them, and the calcinosis, very extensive, consistent with both rheumatoid arthritis and scleroderma, very florid. And I'm sure you've anticipated what I'm going to show in the chest. So let me go to some thin cuts and I have them. We have very extensive basal lung disease, pretty mild, more superiorly, but very extensive subpleural traction bronchiectasis and very extensive honeycombing in the lower lung zones, consistent with, in this case, connective tissue disease associated pulmonary fibrosis with very extensive honeycombing, pretty dramatic. So this person has got both diseases and rather severe, as you can tell from the hands and the lung. And
Howard, what was the connective tissue disease in this person?
sorry, it was both rheumatoid arthritis, David, and scleroderma with acroosteolysis and soft tissue calcinosis. But particularly acroosteolysis and calcinosis. Okay, this is a patient that came in with chest radiographs that looked like this. So we have one, well, actually they're just 1 day apart, so they're going to share the same thing. But we have, I'll put this on the side, we have bibasilar lung disease. These I will simply describe as poorly marginated, confluent, subsegmental sized opacities on chest radiography, left slightly greater than right. And this CT will show you, I'll bring in the thin cuts, what the lung disease looks like. So there is relatively mild disease in the upper lung zones, but there are foci of ground glass attenuating opacity, perhaps a little reticulation. But once we get down here, it becomes pretty florid. Now we have these very confluent ground glass attenuating and even consolidative opacities, left greater than right. Some of the opacities reach the pleural surface, some do not, but certainly one would need clinical context to determine what this is, or what this may be. And it turns out in this person that the thing that was positive, even though his history was not that revealing, was an anti-Jo1 antibody. So by virtue of no findings to suggest an infection, even though he was diagnosed initially here as a pneumonia, it didn't improve. A diagnosis of interstitial lung disease as a manifestation of the anti-synthetase syndrome was made. And this is the most common antibody, autoantibody, that is present in the anti-synthetase syndrome. And typically when we have opacities like this, what do we think they are? Probably a combination of organizing pneumonia and a cellular nonspecific interstitial pneumonitis. And it's likely that both are probably present, but certainly we've seen this before. And when it's severe, it often looks just like this, right? Jeff, you've seen probably more cases than anyone else. This, I would say, in that context is quite typical, right?
Yes.
Yeah. So the history is important. He didn't have, if I remember correctly, seen here, didn't have muscle disease. or arthritis. But he's being treated with mycophenolate, and we'll see how he does. All right, those are my cases. Yeah.
Thank you. Was your rheumatoid arthritis patient a smoker? We had a question from one of the audience members.
Don't know.
Okay. But it is
Smoking,
a major risk factor.
I don't know.
Okay.
See? Is there anything that anyone sees about this that might relate to smoking, particularly? Going back to the lung disease here. No, I don't think so.
No.
But I don't know the answer to that.
Okay. Awesome. All right, Peter, you're next. There we go.
Hey guys, can you see the screen?
Yep.
We can.
Okay. Mine are pretty quick. This is a chest radiograph, and the findings here are, let's see where my mouse is. Okay, just kind of subtle, just innumerable punctate nodules. Much better seen on the CT. So you can see here, just multiple nodules. Some of them are touching the surface, the pleural surface. So this to me looks like a random distribution, a miliary distribution. So some history on this patient. These nodules have actually been unchanged since 2001, and at that time the patient had a hysterectomy. And right after the hysterectomy, they did a lung biopsy. These are the histopathology findings. So this was a case. I know David showed a case of this a few weeks ago, but I ran into this recently. Benign metastasizing leiomyomas, so multiple tiny nodules, not significantly changed at all since 2001, and the patient is completely asymptomatic.
Wow. I think it's the first one that I personally have seen with a miliary pattern. Usually we see relatively few, relatively large nodules.
Yeah.
Sometimes with cavitation.
That's pretty crazy.
It's interesting also the comment in the pathology note. About that was interesting.
So they described spindle cell shapes, and then they said they not consistent with LAM. And then I included this. This isn't from the patient. I just copied it from a pathology outline website, kind of just showing the spindle cell, smooth muscle cells here in between the airways. Okay, so next one. This is a case that you guys have shown multiple times in the past. This is, so we have lobular areas of mosaicism and then multiple pulmonary nodules, and you can see that there's been a biopsy. So this is a confirmed DIPNECH case. These were carcinoid tumorlets. So just pretty good case. I ran into it a few weeks ago and I set it aside to show. So DIPNECH, and then I'm going to show a companion case that I read yesterday, kind of similar but different. So this patient, I'm going to start. I read a chest CT on this patient yesterday, but I'm going to start off by showing the abdominal CT from 2016. So in her initial abdominal CT, she has a mass that's enhancing here, right below the aortic bifurcation. And then a few smaller lesions here, also enhancing. But she has multiple lesions in the liver, which are metastatic. And one of these liver lesions was biopsied, and the findings was a neuroendocrine tumor, most closely resembling a paraganglioma, which makes sense because these masses here are in the region of the organ of Zuckerkandl. And that was also confirmed with multiple MIBG scans were done over the next few years. She was even on I-131 MIBG therapy, and she got somewhat of a good response. But now I'll get to the chest CT, which I found interesting. So on the chest CT, she was noted to have initially mets to the lungs. So this is her initial chest CT from 2016. And then again, you can see kind of a similar pattern to what you expect to see with DIPNECH, mosaicism and then small nodules. So I guess this is also a neuroendocrine tumor. So you have nodules here, and I'm going to show the most recent CT. It's actually not significantly changed. Very, very small interval growth in some of these nodules. And then the mosaicism on this CT, it's still present, not as, you can see lower attenuation here, not as pronounced. Maybe it's due to expiratory phase, but you can see some of the nodules. So I'm wondering if do you guys think this is just typical for paraganglioma mets to look similar to DIPNECH? Or have you seen that before? Because I haven't seen many paraganglioma mets to the lungs.
I don't know.
Seen it cause air trapping, but
Yeah, I don't.
I wonder if it's some kind of similar process pathophysiologically cause the bronchiolitis obliterans type of them being.
Okay.
I mean, the other thing I thought about is, could this be an alternative DIPNECH at the same time? Although that would be a little coincidental. But,
How old is the patient?
I don't remember how old the patient. I think she was middle age to older.
Right demographic. I don't know.
Interestingly, she was also reported to have a history of Lynch syndrome, although this neoplasm isn't really associated with Lynch syndrome.
What is associated with Lynch syndrome?
Colon cancer.
Colon cancer.
Yeah, multiple hereditary polyposis. Don't you remember that from med school?
No, I didn't go to middle schools. They didn't have it in those days.
That's what I was trying to do. I didn't want to say that specifically. I was going to let you.
Yeah, but I know how to put horseshoes on a horse, so I have others.
well, it makes you wonder, Peter, maybe there's some humor secreted by these tumors that do something in the lungs. I don't know. Because, you know, with
Yeah, I was wondering.
DIPNECH, you see the carcinoid tumulate sometimes away from the air traffic. I wonder if there may be something written in the pathology literature. We have to look for it, but if there's any.
I did a quick search on Google. I wasn't able to find much. They just talked about how these paraganglioma mets are pretty rare. So I'm not. There might be something out there, but not sure.
Interesting.
That's all I have, guys.
Excellent.
Interesting.
Alrighty.
Jeff, I have a couple this week. Jeff.
Okay. Yep. Let's see. I'll make you the presenter. There we go.
So I wanted to continue with some paleo radiology, and I was going through Mel Figley's teaching files. Mel Figley was my predecessor at University of Washington, chest radiologist, and goes back to the late 40s, and he was chairman of radiology, and he was editor of AJR in its most distinguished days when they took my my publications readily. So it used to have a glorious history, the AJR. And so these are some of his cases, and they're apropos of some of the ones we've been talking about. These are two cases, first of all, of syphilis with aortitis. So this is the traditional syphilitic ascending aortic dilation or aneurysm that involves pathologically heavy atherosclerosis. So you see this calcification of ascending aorta here in this aneurysm. And And here's the lateral view with the calcification in the rim of this very dilated ascending aorta. So these cases were scanned yesterday. The scanner hasn't been operated for some time, and there are some streak artifacts. Going to try to have these redone after some cleaning. And then let me show you this two other cases apropos. Here's another lateral view of a syphilitic aortic aneurysm involving ascending aorta. Here it is again. Ascending aorta is the favorite location for syphilis, unlike other kinds of atherosclerosis, which prefer distal arch descending aorta and abdominal aorta. Syphilis likes the ascending aorta, but pathologically, it's intense atherosclerosis. And this one has an angiogram, and you can see the big bulging ascending aortic aneurysm. Now, another fun case that was in this set of scanned exams is showing you this bizarre catheter course here. So let me show you this Swan-Ganz catheter that was placed from the left subclavian approach. You can see that it heads medially here. So it's entering the left superior intercostal vein, the accessory hemiazygous vein here. Lower down in the mediastinum, it crosses in one of the retroaortic anastomoses between the hemiazygous and the azygous system. It ends up coming up the azygous vein and then into the superior vena cava, down the superior vena cava into right atrium, and eventually right ventricle. Here's the lateral view. Here's the lateral view showing the posterior course into the accessory hemiazygous vein, crossing into azygous vein, and then the azygous arch taking it back to cava, and then right atrium and probably right ventricle. So a truly snaky course here that illustrates a lot of the venous anatomy of the lung. So I thought these were worthwhile teaching cases. If I can get non-streaky versions, I'll try to post them for you guys. So let me show you this let me see if I can. So Jeff, I'm sorry for the breaches in security here.
We'll take care of it.
Okay. So here's a subtle tumor that popped up in this outside case. And this big tumor here, very smooth margin, seems to have a lot of calcification within. On the lateral view, you know, what can you say about these institutions that display their laterals backwards? But, you know, we deal with a lot of retrograde stuff here. So here's this very big tumor. On CT, you can see that it indeed has a lot of calcification in it. It's just huge. And this woman was becoming symptomatic, so she finally approached a physician. You can see that this thing's having an effect on the proximal airway. It has an effect on the pulmonary artery, nicely shown here in coronal view. You can see how it's leaning on the pulmonary artery here, and it's attenuated around. So, you know, kind of looks like a hamartoma in terms of the pattern of calcification, but I've never seen a hamartoma this big. So they want this out. It was a difficult surgery. They did a sternotomy, and they did this resection of this thing, a pneumonectomy from inside the pericardium. So this is an intrapericardial approach to pneumonectomy, and this thing was removed. And what do you think that turns out to be?
How about
Arsinoid.
Fibrous
a
tumor or chondroid tumor.
solitary fibrous tumor, inflammatory myofibroblastic tumor, looking for rare birds?
Okay, so we have consensus. It turns out to be the world's largest hamartoma. So it's a completely benign appearing hamartoma. So, you know, it'd be fine for a hamartoma except for the size, and it must have just been very slowly growing, as hamartomas do, and so it got to be huge because it was so well tolerated until the end here. So, you know, I think that the hugeness also goes with its being something benign, because it's slow growing enough that the person accommodate, just the way people accommodate huge soft tissue fibrous tumors of the pleura as well. They get to be quite large because they're well tolerated. Okay, so the world's largest hamartoma that I've ever seen. Now, the other about hamartomas is that so-called hamartoma is not really a hamartoma. It's really a mesenchyma. You know, true hamartomas are lesions that should be present from congenital time, and that means that you'll be able to detect them in infants and young children. And the youngest case of so-called hamartoma is really a 9. So these are mostly tumors of middle age, and it's probably really a mesenchyma. And the true hamartoma is probably cystic adenomatoid malformation of the lung, now called something else. But that's the true hamartoma. This so-called hamartomas are really mesenchymomas. But if you're going to take the boards, call them hamartomas because that's what people expect.
So David,
Howard, I think I some comment you were going to make.
well, David, I was going to say that I agree with you about the hamartoma mesenchyma issue, but I don't think the congenital pulmonary airway malformations are necessarily hamartomas, maybe one subtype, because they're airway malformations, and it's usually because of a foregut budding abnormality rather than a true mass, like of just disorganized tissue.
Yeah, I think that case would be strong if you had mesenchymal elements within the the airway elements plus the the epithelial elements and the mesenchymal elements. That would make it reasonable to call that a hamartoma, but I'm not able to address your question with any more sophistication. Okay, so the world's largest hamartoma, I'm going to let it go at that.
All right.
And then I think I'm going to be able to bring up another case here. Yes, indeed. So here's a person who has an immune deficiency. So this is an acquired immune deficiency, and this person has a lot of airways disease, as you can see, and most of the nodules that we see are really associated with airway. So they're blobs within the airway or they're inflammation around the airway. And then this person also started to show up at varying times with these faint ground glassy abnormalities like this. And people were concerned with this CVID diagnosis that there is a potential for developing lymphoma. And so this sort of lesion got biopsied. And you can see that there are a couple of other instances of ground glassy, smudgy things floating around in these lungs. So here's another one right here, for instance. So another consideration, I think, would be an adenocarcinoma in this setting for these things. It turns out that these were sort of steroid responsive, though. They would go away when the person was given anti-inflammatory things like steroids. The person also has lymphadenopathy that looks like sarcoid. So very nice, clean mediastinal nodes enlarged in mediastinum and hilum. Plus these smudgy things in the lungs. So this got biopsied, and they detected they got granulomas out of this, non-caseating granulomas. So sarcoid-like findings in the setting of this immune deficiency is just fine for GLILD, and so that's the diagnosis they're carrying in this case. I think there are some other sarcoid-like findings. For instance, these little nodules along fissures here fit for the peripheral nodules. This is not airways disease in this location here. This would be also another good finding here for sarcoid-like nodules. So manifestations of sarcoid in this. I know there was a case last week where that was this GLILD was the presumed diagnosis. I think this is our case. The recent case here that also fits with GLILD. Okay.
And this one, David, in the context of CVID with hypogammaglobulinemia, presumably.
Right. Yeah.
And David, if you look carefully on that image right there, it's like the, sort of the fairy ring sign where the reversed halo is, if you look at it closely enough, is actually made of tiny nodules. The descriptions of sarcoid as ground glass looks
right
more tiny nodules than true ground glass nodules like you see with adenocarcinoma.
Yeah, good point. So you can actually see that this is a little cloud of very fine nodules. Yeah, that's
If it was
the
a sharper
galaxy.
curve, yeah, exactly. Sort of a, yeah, that's almost like, yours is almost like a halo, reversed halo, sort of fairy ring variant.
Yeah, I tried not to go into these gender issues though, so I didn't want to bring that up. Yeah.
Okay.
Okay.
All right, Travis is going to be next here.
Okay.
I like that. That's
Thanks, David.
So David, this first case I'm going to show here, my fellow will attest that I had this already loaded and ready to go. But this is a catheter adventure case, and you know, and I will swear to everyone else in the audience that David and I did not coordinate these cases. His from when was yours from? Like 1982 or something, you said?
Yeah, it's
From
fairly
today?
recent. Yeah. I think it was taken by Conrad Ricken, right?
This patient has a tracheostomy, and so they've got long-standing illnesses. They're fairly young, but have had multiple indwelling catheters and had this peculiar, you know, course. And when I first looked at this, I was wondering if this is some weird pigtail catheter, but of course then you see it continues along and goes down and then back up. So just in a general sense, could be some sort of venous, extravascular, or unlikely to be arterial in this case. So this was placed, I don't know where, but they went to IR to have this thing investigated further. And so they started with this fluoro where they rotated the C-arm around, and you can see, just as your case showed, that this is going, you know, posterior, kind of wrapping around the aorta and swooping back up. And when they did the injection, sure enough, this is in the azygos vein, just as yours was, via hemiazygos vein and crossing over here. So I had not seen this particular kind of configuration until 10 minutes ago when you showed your case. And now here's another one. So I think this is superior intercostal vein here on the left, coming down into the hemiazygos, and then across right about there into the azygos. So this is one, this CT is from a while ago, but I pulled it up just to show as a comparison.
Yeah. Is it, so
No.
Travis, is this the same case you had the plain films on and the angio, or is this a different?
Yeah, no, this is the same patient. This is the patient from, this is them a few months ago though. And
Okay.
I don't know if the left brachiocephalic vein is occluded here, and it's hard to tell if it was already, if it's just severely stenosed or occluded. But yeah, this catheter was placed into that and then around. So this is the same patient.
So, you know, it's actually that, you know, that upper branch of the hemiazygos system is called the accessory hemiazygos, when it's the top half of the chest.
This? Okay.
It's called accessory hemiazygos. And that's what the LSIV, the left superior intercostal, goes back and it drops into accessory hemiazygos. So if you want to be finicky about the terminology.
I did hear you use that term, and I was, you know, okay. But then, so down here would be, I guess this would be hemiazygos below when it crosses.
Yeah, that's right.
And then this is, okay, interesting. So that's accessory hemiazygos up there. Very cool. So, and very ironic that I have that case to show too. Completely unplanned. All right, this one hits a few good diagnoses, and we'll start. This is, as you can see, a 42-year-old, and he had 2 PE studies done at outside hospitals a few weeks apart, both called positive for pulmonary embolism, neither of which I believe, as you can see here, that there do appear to be filling defects in the pulmonary arteries. However, if we look at the left side, we have some contrast making it into the left, perhaps right here across a patent foraminal valley, but we really don't have much in the pulmonary veins, especially in the lower lobes. And if you look at where these filling defects are, these of course look like smoke. They're ill-defined wispy filling defects, and we just have outrun the bolus here, I think, in both of these cases. And well, in this one, and now in this example as well. So this was done like a month, you know, within a month of that other one, and you can see similar but slightly different configuration. So it's got bad pulmonary hypertension. You can see the pulmonary or the right ventricle is dilated, hypertrophied, and the question is why. And then you look at his lungs, and you know, these are the ones that when you first look at them, you wonder, is this just really bad honeycombing, and is this really bad UIP pattern in patients with fibrosis? But you can see there's a few things that don't fit with that. A, there is some subpleural sparing here, and B, there's really no traction bronchiectasis at all. These airways, you can follow through all of this stuff. You know, he's had a prior surgical lung biopsy here. He does have a little bit of a dilated and patulous esophagus, and there's no reticulation. So these are, you know, I've shown a few of these cases now. I think we've seen multiple. This patient did go to lung transplant in the interim, and this was all end-stage NSIP. So these are all cysts, all related to his connective tissue disease, rather than just a UIP pattern of fibrosis. Moreover, there's a little bit of hemorrhage, but they didn't comment anything on seeing any sort of thromboembolic events. So, you know, when there was the 3-category UIP, possible UIP, and inconsistent, this was the definitely not possible, because you either call it inconsistent, or if you think it's honeycombing, you call it consistent. This is one that, you know, for these reasons is inconsistent and supported by path.
So the smoke may be a combination of slow flow, but maybe also anastomosis between bronchial arteries and pulmonary arteries.
Yeah, exactly. There may be, right. And also the slower flow in the lower lobes where you have more severe fibrosis. So you have increased vascular resistance there also, you know, and just early timing, like we said. So, okay, Jeff, I will stop there.
Okay.
I have some cases if you want me to
Sure.
show. Let me close all this out. Sorry, let me log out. Sorry, let me just hold on 1 second. Just gotta get all this PHI off of here. So this is a case of, and I showed this before, but I'm gonna show it again because it's just dramatic in terms of what happened to it. So this is a patient who presented, had these little, if you look, there's scattered areas of kind of nodularity, some little cystic areas, but they're actually, again, these kind of strange nodules. They're actually lower lobe predominant. You can see them here, some cystic change. And I'm pretty sure I showed this case, and I've showed other cases like this in the past where you see these kind of bizarre nodule cystic change, but instead of being upper lobe predominant, they're lower lobe predominant. So this patient, I'll show what happened to her. She was kind of cruising along. Those nodules actually got better, went away for the most part, and then had a serious badness occur. So then she presented about a year later and presented with pneumothorax, and this is actually a PET study. And again, you can see these dramatic worsening of these nodules. You can almost even imagine where the pneumo occurred due to one of these nodules perforating through the pleural into the pleural space. But you see that these nodules and cysts have reoccurred, and they're overall much worse. And if you saw this in the upper lobes, you would say, oh, it just looks like PLCH. And this is kind of the same thing. This is a malignant histiocytosis. So this is a patient with a known malignant, where's my fuse PET? Oh, come on, man. Here we go. This is a patient with a malignant histiocytoses, and I've showed a couple of these, and they all tend to be lower lobe predominant instead of your typical upper lobe predominance with most. Here we go, see if I can get this to load, please. So this is a patient with malignant histiocytoses. Oh, that's just the leg portion, super. Let's see if I can do this again.
Is that how old is this person?
30 something.
Okay.
And I've showed other, let's see, hopefully this is it. Yeah, so she had a biopsy proven in her thyroid, anterior mediastinum as well, and all over the place. And you can see there's not really here as well, but if I showed it on the actual PET, there was kind of diffuse uptake in the lower lobes. So because it's not an inhalational lung injury, this is actually due to malignant deposition of histiocytes. You would assume that it's going to be a lower lobe predominant process. which it is. And every malignant histiocytosis I've seen has always been low, but it looks like PLCH in the lungs because the histiocytes, or Langerhans cells, they're normal antigen presenting cells, and they are there to damage structures, and they do just that. This case I showed very quickly a couple people. I don't know. I don't think I shared it on here. Maybe I didn't. I'm just kind of forgetting things. But this is a guy who has colon. I actually told these people I showed it to just prostate. He actually has colon and prostate mets, which makes a little more sense. So this guy presented and has, he has metastatic disease, and then presented with a couple new thyroid nodules, and if you look, his mets are just much worse everywhere. So presumably these are metastatic lesions within the thyroid. I've seen it with melanoma and renal cell before. This is either due, I'm assuming, colon cancer rather than as prostate, but I've not seen it with that malignancy before. So those are thyroid mets. This is interesting. So let me show this here. Wait, where is it? Which one is the here? So I always assumed that this developed very early in life, but I guess that's not always the case. And I always assumed it was relatively stable too. And this is a thoracic spine MRI, and obviously I don't care about the spine, but I'm doing this. This is 2001, and you can look in the region of the interstitial septum, and there's a little bright signal there on the T2 weighted sequence. Here is just a localizer where you can see, okay, little lipomatous hypertrophy. Kind of fast forward to a few years later, and the gentleman has, much more pronounced lipomatous hypertrophy. He actually presented with arrhythmias, and they tried to do, I guess, at some point, not too long before this, about a year before this, you can see as quite a dehiscence, that he underwent some debulking of this. And what's interesting, I was debating about with one of my younger fellows was, does these ever actually cause SVC obstruction? He found some case reports. Every case I've seen, which I have CT and MRI of, show narrowing, but the patient don't actually have superior vena cava dilation. And on MRI, if you look at, this is the MRI obtained around that time. Let me just find the best one for the sake of time. See if I can get this to play and get it to move. No, I can't do that because that would be too easy. But basically, if I was able to load this, you would be able to see that this does not cause any sort of obstruction. Yeah, anyways. One of the major limitations of Terra-Recon is the ability to look at these MRIs with some ease, I have to say. Anyways, not going to be able to see. Yeah. So anyways, if it wasn't causing seizures, you would see that the SVC is narrow, but there's no limitation of blood flow through that. And then this guy's been followed up over many years, and if you follow this thing, it's continued to grow. So they've resected. We've done additional MRIs on it, and you can see the SVC narrowing looks quite intense. But we did another MRI, and there's still no obstruction. And very importantly, this is not a mass. Well, it is a mass. This is just lipomatous hypertrophy. You can see if you do a good reconstruction that there's still sparing in the region of the fossa ovalis down here, which we've also showed with some MRIs. So it's just an interesting progression where in 2011 you just had a little bit, and then this thing has continued to really explode and grow. I don't know how many other people have seen the natural progression of lipomatous hypertrophy, but I thought that was kind of
Is there
interesting.
Anything interesting in the pathology, since you said he had a debulking? Did they comment?
No, they just called. They just called it a lipoma, which they always do because they just get a ball of fat. No, they do. I mean, you ask a pathologist, can you differentiate lipomatous hypertrophy from a lipoma? They look at you like, they're like, no, it's just fat. Like sometimes there's more brown fat, but
yeah, that's what I kind of was getting at. Did they make a note of anything like that, more brown fat than the usual?
I'll look at the pathology. I don't remember there being any specific distinguishing thing from my understanding. And this is just a weird case. I don't know if anyone can explain this to me, if I can get these two to be unlinked. So these studies are done 4 days apart. And if you notice where the abnormal, this patient comes in, we're not really sure what it was, viral pneumonia, drug toxicity. But if you look, see the dates here. Yeah, they're 4 days apart. And if you look on one versus the other, like this area here is kind of cleared and all the area around it is worse. Same thing in the lower lobe. If you look, the area that was involved is clear and the rest of the lower lobe is involved. Same with this kind of streak band here in the right upper lobe adjacent to the fissure. That area is resolved and the rest of it is now involved with this ground glass. And kind of everywhere you look, you see that weird pattern that the areas that were most pronounced involved are actually spared on the most current study, which is literally just and she's a patient with lung cancer who was on a chemotherapeutic agent. I don't know. This one was just very odd to me. It was like I was saying, it was like almost a photo negative of one versus the other. You can kind of see here where, spared, and now the area around it's involved. Can anyone explain? I mean, I was trying to think 2 different instances of lung injury. One that was, the first one was somehow protective or limited the injury of the second because of, I don't know.
What agent was involved here, Seth? Do you know?
I do know, but I don't know. The answer is someone told me what it was, and I don't remember what it was. It ended in MAB. What was it? It ended in MAB. It was an immunotherapy.
Got it.
Yeah, that's pretty fast for an organizing lung injury to appear and disappear that quickly.
Yeah, no, that's what's so weird about it.
You think, and it's, maybe something like edema or something like that, but even that is so, there's a little septal thickening, but the left lung is relatively spared.
Yeah. And she has, she has tumor there and narrowing there. I don't know. Inhalational injury, decreased airflow. I have no clue. It's just really odd. And the rapidity of how it comes in, it literally is just like the photo negative of it. It's weird. All right. Sorry.
Interesting.
Yeah.
All right. Is there anyone else who has cases? All right, I can show a few here. All right, so I will start with everyone see a perfusion scan. All right, so you can see this is very abnormal, and I'm doing it a little bit backwards, but that's what makes the case interesting. And you can see that there's very little perfusion to the right lung. It's primarily in the right lower lobe. There's the RPO there. You can see that there. So when we see a perfusion scan about this, you could have a PE, but the fact is the left lung is normal, so that's unusual, especially when you have just an entire lobe spared, but a central mass or some other central occlusion. Here's the chest radiograph. This is the PA view, and you can see there's an effusion. The right lung is a little bit smaller than normal. There's some volume loss in it as well. And then this is a CT scan. I'll change the window a little bit here. And there's a bunch of collaterals in the chest wall. There's an aberrant subclavian artery. We see this effusion. And then if you see, pardon the robin here, you see in the mediastinum, there's this mass with some dense material in it. And then a lot of collateral vessels here. The pulmonary artery is open, but if we go down to the pulmonary veins, you see the inferior pulmonary vein is quite narrow. There's a little sliver of it maybe coming down right there. And then the superior pulmonary vein is mostly out. And then again, the SVC, of course, is really nowhere to be seen. it's in this big mass here. So this is a nice example of fibrosing mediastinitis. And you see a lot of collateral flow retrograde through the azygos. And in this case, the accessory hemiazygos is filled up because I think the azygos is out. And then branching down here and going up to the abdomen, paraspinal everywhere. So this is presumably from histoplasmosis, a Midwestern patient. It's got the big calcific mass, which and it is the most common, but typically when you see this, it's more likely related to histo than when it's just non-calcific soft tissue. And then if we look at the lung windows, you can see just the effects of the impaired venous drainage and just overall poor aeration of that lung. There's bronchial wall thickening, which is probably lymphatic and venous, just edema in the lung from the impaired venous and lymphatic drainage. We can't see the lymphatics, but the presumption is they're also obstructed because the veins are out.
Oh, how about the spleen? Do we have calcium in the spleen? Like histo?
No, but it doesn't rule it out. Given it's a Midwestern, I'd bet on histo. All right, well, since you showed some, let's see, I have a little time here. So I may have shown this case a while ago, but I actually have a diagnosis now. So this is a 60-year-old male who has a history of renal cell and is on a TNF alpha inhibitor. I think it was renal cell, I don't remember, but and I noticed this thickening along the subclavian artery there, and then there's even a little bit in the right brachiocephalic artery, and then a little bit of aortic thickening, and then if you go down right, you can see down in here that was all new. When I've got has an IVC filter in, and then I've got here's the abdominal portion, shows right renal artery involvement. So a lot of thickening of large and medium-sized arteries in renal. Some of this is atherosclerosis, but some of this was not, and this was not. So, and this was a new finding. So this is a case of vasculitis. They made the diagnosis, I don't know, with a biopsy, I think, of the skin, but it's a drug called pazopanib, which is TNF alpha inhibitor. So it has been reported to cause a vasculitis. So while we see a lot of immunotherapy and sort of these other drugs in the lungs, it can also cause vasculitis as well. So add that to another list. Pazopanib.
How do you spell that?
Pazopanib.
Oh,
okay.
Causes a large vessel.
Yeah.
Wow, that's interesting.
All right. So David showed us some paleoradiology. I'm going to show you some neoradiology. So this is another case of syphilis, but this is you can see a modern CT scan here, contrast enhanced, and this patient has striking wall thickening of the ascending aorta. You can see some atherosclerosis and a little bit of descending aorta involvement, but this is primarily in the ascending aorta. I have a couple of studies, and I can't remember the time frame of these. This was a little bit earlier on, but I think it just shows a gated study here. Quite a bit of thickening here. And then I have another case. These are the two cases I've encountered in my career, other than the ones that have been shared with me. And this is an MR, and you can see quite striking thickening of the ascending aorta. And let's see, I have here's an axial stir image, and you can see quite a bit. Oh, these are single shot. Let me find the lower down image. Here we go. So you can see there's a little bit of motion, but there's quite a bit of edema in the wall here. And this is just another black blood image here showing the thickening, and then even in the descending aorta. So these are both cases of syphilis aortitis. And then here's a nice sagittal showing that. And as David described, and this is probably in a more acute or subacute phase where we have more thickening and we haven't developed the calcifications and striking dilation at that time.
Very impressive.
So more syphilis.
Guys, I think we've mastered syphilis of the aorta in these last several weeks. This is great.
Yeah. No more COVID now. No more syphilis. We'll have to find a new infection for next time.
Right.
All right, everyone. Well, it is the top of the hour, so we'll call it a day.
Thank you.
Great.
All right.
See you next week.
All right. Bye.
Thanks, everyone. Good weekend.
You too.